I invite Dr. Sanjay Shah for his talk on recent advances in polytrauma management. Sorry. Dr. Sanjay Shah is MS DNB, he is gold medalist, FNB Trauma Care from Mumbai. He is course director and faculty, ATLS India. He is president IATCC ASI, head of emergency department and senior consultant trauma surgeon, Apollo Hospitals, Ahmedabad. We welcome you, sir.
Thank you very much for those kind words. From the outset, I would like to thank office bearers of organizing committee, Gujarat Criticon 2022. I would be limiting myself towards certain research because otherwise it is very difficult to cover it in short time. But those research which has been included by ATLS guidelines, as well as certain research which has changed the clinical practice of trauma care. So how resuscitation evolved over time, certain aspect has been taken care of by Dr. Harjit in sepsis, but I would be talking in trauma care. So 8th edition of ATLS, which came in 2008, was recommending it of around 2 liter of crystalloid to be infused over next 10 to 15 minutes of those patients who come with the traumatic hemorrhagic shock in emergency department, to give it as a fluid bolus and to decide about the further response of the patient, whether it is responder, non-responder or transient responder. At that time, there was not much concept emphasis on balanced resuscitation, because at that time it was just under evolution. And in 2012, this was the 9th edition of ATLS, which did reduce from 2 liter to 1 to 2 liter of crystalloid as a fluid bolus, and certain component of balanced resuscitation was just touched upon, but it was not shown in detail how to go about it. And it is the 10th edition of this ATLS guideline which restricted it to just 1 liter of fluid bolus for hemorrhagic shock of trauma patients, and recommended further to use early use of blood and blood components, particularly in class 3 and class 4 hemorrhagic shock. And to prevent coagulopathy in trauma, especially, also there is emphasis on massive hemorrhage protocol or massive transfusion protocol, with what we call. And there is an inclusion of tranexamic acid that we all know about from CRASH-2 trial studies, that 1 gram of tranexamic acid loading dose and 1 gram over the next 8 hours as infusion in trauma hemorrhagic shock. So what changed the practice over time in trauma is due to the understanding of shock physiology better, and we now know that achieving the normal blood pressure in trauma patients before the control of the hemorrhage is going to be very detrimental, which increases the chances of further rebleeding, exacerbates the triad of death, and it does activate the inflammatory cascade. And yes, one should try to prevent the coagulopathy to set in early, and if at all, then we should treat it very aggressively before the patient lands up in bloody vessels cycle. There are certain terminology in resuscitation, like damage control resuscitation, hypotensive resuscitation or permissive hypotension, hemostatic resuscitation or balanced resuscitation. Certain terminology are like they are just synonym, like hypotensive resuscitation or permissive hypotension, but not all are same. We'll just understand how they differ from one to another. This one study which came up and changed the practice of resuscitation in trauma patients is damage control resuscitation, which here it shows that there is association with a reduction in the resuscitation volume and improvement in the survival of those patients who underwent trauma damage control laparotomy. Now, usually we go with the overzealous resuscitation, and that's what the trauma resus was for last couple of decades. But now we know that before the surgical control of the hemorrhage, if at all certain component of the patients do require, then we should not go with the overzealous fluid resuscitation, rather control. And same is true for penetrating trauma patients particularly. It has started with the penetrating torso injury and then got extended into the blunt injury as well. That is called as permissive hypotension or hypotensive resuscitation strategy. which reduces the transfusion requirement, at the same time reduces the severe postoperative coagulopathy in trauma patients. Now here the catch is we should try to rule out the head injury component of these patients. If patient is having associated head injury component, obviously we should not go with the hypotensive resuscitation, but MAP should be targeted at around 60 to 65. But if it has been ruled out, then this would be a better strategy with a better outcome. So when we want to revise the strategy of damage control resuscitation, it has a 3 component in it. The first component shows that balanced resuscitation or hypotensive resuscitation to start with, and which shows that there should not be aggressive or overzealous resuscitation in emergency department. But at the same time, certain patients, particularly with class 3 and class 4 hemorrhagic shock, we should go for early correction of coagulopathy by hemostatic resuscitation, or in certain components like severe pelvic fracture, we might initiate the massive hemorrhage protocol, and along with that we can give antifibrinolytic as well. And the third component of damage control resuscitation is damage control surgery itself. So here the damage control surgery is a part of resuscitation strategy, and that's how it completes the spectrum of damage control resuscitation. Unlike, there are certain strategies like hypotensive resuscitation or hemostatic resuscitation has a component of it, but collectively together this would be falling under the damage control resuscitation. When I was in my trauma training, we used to do many damage control surgeries, and that was due to the lack of knowledge of underlying physiology for shock, and not having associated component therapy or hemostatic resuscitation strategy. So many of the patients were falling into the damage control surgery, but now much of the studies are going which prevents them to go for damage control laparotomy or damage control surgery. Rather, we should limit it, and with a better hemostatic resuscitation, surgeon can aim for completion of the whatever injury pattern it is there definitively, then damage control. So in short, the balanced resuscitation is a very tight control between the organ perfusion on one side and avoidance of rebleeding on the other side, by accepting willingly that lower blood pressure than normal blood pressure is good enough for this patient, just to maintain the urine output of the patient, and cerebral circulation should be good enough, and hemostatic resuscitation or hypotensive resuscitation would be a part of it. Coming further on to the other changes which has come up in particularly with the thoracic trauma, we all know that tension pneumothorax, we do needle thoracosynthesis in second intercostal space mid-clavicular line, but the newer guideline says that the site has to be now from second intercostal space mid-clavicular line to fourth or fifth intercostal space mid-axillary line, same site as intercostal tube drainage in adult patient, though pediatric patient the site remains same as second intercostal space mid-clavicular line. Why it is so? Because from the German autopsy study, it has come up that those patients who are obese, those who are masculine, the needle thoracosynthesis might not be good enough, and it might not have punctured the parietal pleura and not relieved the underlying tension pneumothorax. And anyway, you are going to be, for the needle thoracosynthesis is to be followed by ICD incision. So it is very easy to remember, and better for certain patients who are masculine, then also this site can easily relieve the underlying pneumothorax. Again, for hemothorax, the advice was a larger diameter of intercostal tube drainage, like 32 to 36 for adult patient and 28 to 32 for female patient. Now, with a better understanding of that physiology also, the larger diameter of ICD is not being recommended. 32 for male and 28 for female is just sufficient. And for blunt aortic injury, we all know that control of the heart rate along with the control of the blood pressure will reduce the chances of further overt rupture of that underlying aortic injury, and target heart rate should be 80 with the mean arterial pressure of ranging around 60 to 70 millimeter of mercury if there is no further contraindication. In abdominal and pelvic trauma region, whatever the guideline has changed is one good dictum for surgical training was, if you do not put your finger in rectum, then you are going to put your foot in. So here it has changed. Now palpation of the prostate gland does not rule out the underlying urethral injury, and pre-peritoneal pelvic packing has come up into the protocol of pelvis fracture, particularly those patients who are hemodynamically unstable, along with the angioembolization. So that wherever the facility of angioembolization is not available, or if patient is unstable, it is better to go for pre-peritoneal pelvic packing, which is equally sufficient enough to control arterial, venous as well as bony bleeding. In head trauma, not much change has come up, but yes, we are going to prevent hyperventilation for prolonged duration and maintain the systolic blood pressure of around 100 to 110 millimeter of mercury. Propofol infusion is not going to reduce further metabolic demand and reduce the ICP, so that has come out of the guideline. Mannitol is still remain the same, but 3% NS is now equally good, and it's better without having any withdrawal phenomenon, rebound phenomenon. So it's better to use 3% normal saline. And phenytoin is being recommended to decrease the incidence of post-traumatic seizures within first week of head injury, and that has been taken up by Brain Trauma Foundation as well. Same for resuscitation for burns patient. Now from 4 ml per kg per percentage of body surface area of that burn patient, now it has come up to 2 ml of ringer lactate, then so it is reduced to half for resuscitation, and fluid titration should be based on urine output and further investigation modality. Avoid fluid boluses unless the patient is hypotensive. So again, boluses should not be given otherwise. And in pediatric patient also, it has been restricted to 3 ml per kg per percentage. For pediatric injury patients, damage control resuscitation again holds true, and again here the emphasis is being put on reduction of volume of crystalloid for resuscitation and early use of blood and blood component whenever they require. Many of us are doing certain investigation, particularly CT scan or MRI, for those trauma patients who require transfer to a definitive care. So it is now not being recommended because anyway receiving center is going to repeat it. So it does increase the delay of transferring to a definitive center, as well as there are radiation induced hazards. So you should prevent if you are by any chance transferring patient to higher center. Coming to certain other research areas like major hemorrhage protocol or massive transfusion protocol. This is very, very important wherever there is in-house blood bank and you are receiving a class 3, class 4 hemorrhagic shock of that trauma patient. It is very, very important to go directly on the component therapy early and on aggressively with the 1:1:1 ratio, so that it does prevent the precipitation of coagulopathy in these patients, and if at all there are, then it reduces the mortality due to the coagulopathy. Here the proper study shows that either if you are giving 1:1:1 compared with the 1:1:2, and both are equally safe, but there is a reduction of or rather early prevention of coagulopathy, or the mortality due to the exsanguination was very less compared to 1:1:2. So the take home here from it, for major hemorrhage patients, you should go with the 1 PCV, 1 platelet, 1 plasma, rather than going for multiple transfusion of blood product, then going for platelets or plasma. We all know about thromboelastography. That is nothing new, but Rotem was once upon a time a point of care, a good adjunct in emergency department or ICU to understand about the patient's coagulation profile and whether they are going for coagulopathy and for correction of that coagulopathy. And it was advised, but now with the recent study, it has come off from the recommendation. Yes, it is a helpful adjunct, but it does not show any statistically significant difference in the outcome if it is being compared with the massive hemorrhage protocol 1:1:1 therapy. So if you are practicing that and if you do not have Rotem, does not make any difference. But yes, Rotem will make a difference if it is available in reducing the number of the component transfusion. One more important study which has come up in 2020 only in Journal of Trauma and Acute Care is pre-hospital patients when been transferred to a trauma center and they have been collected for ionized calcium that was found to be hypocalcemic, and it was associated with the lower survival as well as requirement of multiple or other massive transfusion. So now the evidence is going in favor of giving supplemental calcium to each patient, those who are coming with the hemorrhagic shock early. Tranexamic acid from CRASH-2 trial been extended into the CRASH-3, and in intraparenchymal head injury patients, wherever there is intraparenchymal hemorrhage, you can extend it to further 24 hours in infusion therapy to prevent expansion of that hemorrhagic component in intraparenchymal. Resuscitative endovascular balloon occlusion of aorta is being practiced for last couple of decades in developed countries, though in India it has not come up, and indigenous modification have been started at certain centers. It is quite helpful agents for those patients who are coming with a life-threatening hemorrhage, especially torso trauma and pelvis fracture. There are the three regions where the balloon can be inflated: supradiaphragmatic for intrathoracic hemorrhage, infradiaphragmatic and suprarenal would be for intra-abdominal hemorrhage, and infrarenal deployment of balloon for pelvis fracture. So if you can do that, it can give you another 45 minutes to 1 hour of around further management, so that the patient can be wheeled into the surgery or angio suite to control the hemorrhage surgically or DSA wise, and it gives you a good enough time for improvement in the survival, because many of the some patients who are class 4 shock might not be able to reach otherwise for the definitive control of the hemorrhage. The last thing is one of the very recent topic of fixation of the rib fracture for flail segment or multiple rib fractures. It is quite close to my heart. This is one of my patients who had significant flail segment with the intrusion of the thoracic segment into the left side of chest. If you can see the volume of the right side of the chest and left side of the volume, even it is not half of the right side, and patient was subjected for fixation of the rib fracture with thanks to the better devices like plates and screw, which are self-drilling, self-taping. And unlike previously we were used to fix with the SS wire, which was very easily getting extruded. So this was the pre-op X-ray, and this is the post-op X-ray. Now complete or rather good expansion of the left side of the chest volume. Patient was within 24 hours weaned off from the BiPAP support. Patient was mobilized on day 3 and got discharged on day 7. So from the consensus guidelines, it is like a white paper guideline and not come up to the textbook yet. But those patients who have more than 3 rib fractures, or there is a presence of flail segment or uncontrolled pain despite of multimodal analgesia, or those patients who had a failure of weaning from BiPAP or Venti, these are the patients who will be benefited from the fixation of the rib fractures. A couple of the publications by me in the same segment, and one of the series is under publication of 20 patients. Thank you very much for patient listening, and if there are any questions.
Any questions?
I think thank you all the 3 speakers for this excellent talk. And I think what I can conclude from listening all these 3 experts, that being intervention cardiologist doing primary PCI is much more easier than what I'm listening here for last 3 hours. It's really, I can salute you all. Critical care is very complicated subject, and especially in the patient with like post-transplant infection, polytrauma, it's a nightmare to manage. I just have one question to the all who's expert here. Like as you said, post-transplant, immunocompromised infection and everything, polytrauma patient, what is better for Indian healthcare system? Do you think nowadays the organ transplant is increasing in India, and more centers are doing that? Do you think that is better, or you should have limited centers with the higher expertise is better? What do you think in Indian population? Because everyone is in race of heart transplant, means organ transplant everywhere. And you said the critical role is intensivist. All the failure of success depends on how you manage post-operation. Surgeons operate, then they disappear. But then all the setup, team effort, which is very important, and still everyone is trying to do the transplant center each and every district. What do you think? Is it better, or do you think
Sir,
a limited center is better?
Limited center is not going to happen, sir. And every major hospital wants to have a transplant unit. So as it's very, very lucrative, I'm very, very open with this. So many major hospitals want to have an independent transplant unit of their own. So what we have to have is an excellent integrated transplant team in the hospital. So for that only I was stressing the need of a very good microbiological team, which is extremely crucial. Apart from that, a transplant intensivist, if possible, and then an ID specialist. If they can complement the hard work put in by the transplant surgeon and the transplant physician, I'm sure we can definitely get over this problem of transplant infections. So limited centers, it might be very, very difficult in an Indian setting. I think we must have dedicated transplant units with a multidisciplinary team approach. That will be the answer, yeah.
When I was in UK, they have very limited centers. In each area they select and all triage the patient, right? They send the patient there, right? Here now every district, do you think every district hospital will be able to capable of managing all these infection protocol and everything in our area? Because there is no point to transplant surgery and then you leave the patient. Ultimately, the outcome is more important than the more center opening.
Absolutely, sir. I take your point. In National Health Center in UK, there are very, very dedicated centers, limited centers there. But in an Indian setup where there is a private-public partnership, in the sense we have a lot of hospitals in the private sector also, which are complementing the hard work done by the government sector also. That is what we are having in Indian sector. So here I think the centers will be much more. Definitely we may not be able to restrict to a particular group of places where we can have transplant centers. But at the same time, we must have a dedicated team, because finally the organ survival is very, very crucial. So we cannot be doing transplant irrationally here and there. We should have a very dedicated team. I think there are a lot of very good centers coming up in India, yeah.
If just
One more thing on a lighter note. There are 35 medical colleges in Gujarat. So where these doctors would go?
one more.
Exactly. To come up with the first transplant, it always happen in the Apex Institute, but then it will percolate to the.
Try to focus that institute to develop more, so they can have more research, more resources, rather than.
Exactly, that is going on. See, I am attached with the UN Mehta Hospital, and they have recently done first transplant. Right. So the first, it was done by the SIMS Hospital, if I am not wrong.
Yeah.
And then. Huh? Exactly. Though the day is not far that other hospital will also get involved. Publication, research works are also going on in the hospital simultaneously. But as the doctor has said that we are 130, 140 crore populations. So I don't think that a few hospital will cater the population.
If I
It is like your cath lab now. It is there in every probably districts and taluka. I think we should keep the science going on, as Dr. Ebenzer said. We should have set protocols, and that is how we roll on. And again, infections, because they are the major worry in India, the mere reasons why we are not stressing on more lung transplant. I think Dr. Arjit has already started a unit. So infections should be taken care. Rest transplant patients only need a good surgical hand. I think then, and of course, as he said, public. So you need good money and a package, defined stay, defined algorithms to manage it well.
Just to add up on just one comment, if I correlate that analogy with the trauma center, the same conclusion was there. Why we do not have a dedicated and designated trauma center, and why there would be a trauma system at each and every hospital. So I am a proponent of like this, that every hospital should have a trauma system rather than a designated trauma center, because the many patients will not be able to reach to those. Looking at the diversity of the India with the population and all that, yes, there are challenges, and challenges would be there for the first center as well. Like SIMS did, say for example, heart transplant first time, so they had challenges. The same thing UN Mehta would have, but at some point of time, after a few more, they would be experts. So you should aim for the best, but restriction should not be the better strategy. That's what
all of you will agree with me that a decade back, transplant teams were flying across the country. From one city, they'll be hopping to another city. They were predominantly flying to metropolitan cities, but now they are flying to Tier C and Tier B cities. Okay, that's how it is. But still, I think a lot of centers are coming up, and they're able to do a good job. Yeah. But point taken. The organ survival is very crucial. Yeah. Thank you.
I think thank you all the dignitaries who gave their very informative speeches that did not only emphasize on the evidence-based medicine, but also inspired us to inculcate the strategy of using WWW, what to start in our patient, when to start, when to stop, and why to start. So if we inculcate such why questions in our practice, that strategy along with using evidence-based medicine is going to have a big impact in the practice coming in the future. Thank you very much.
Thank you, chairpersons. Thank you, Sanjay sir.